Hi, my name is Marlyn Gonzalez, and today I'm going to be presenting otitis to you. So some of the important parts of the ear that we are going to be looking at are the auditory canal, which is part of the outer external ear, the tympanic membrane or eardrum, the tympanic cavity or middle ear that form part of the middle ear, and also the eustachian tube, which forms part of the inner ear. We need to know that the eustachian tube does form part of the respiratory system. So, what is otitis? Serous otitis media, also known as otitis media with effusion, has no infection present, but there is a buildup of fluid in the middle ear. The buildup of negative pressure in the ear pulls fluid from the capillaries into the middle ear space, causing an effusion. Acute otitis media is an infection in the middle ear, and it's usually caused by an upper respiratory infection. There is a buildup of mucus and serous fluid in the eustachian tube, and this provides a very nice area for bacteria to grow, so it becomes a perfect breeding ground for it. Next, we're going to talk about chronic otitis media. So chronic otitis media is actually a frequent acute otitis media, and that can also be caused by a dysfunctional eustachian tube or trauma. An example of trauma would be perforation to the tympanic membrane. What are the risk factors for otitis? The first one would be young age. Eustachian tubes in children are horizontal and shorter. In reoccurring otitis media, we educate the caregiver that as the child grows, they will have less infection. The next risk factor would be exposure to secondhand smoke. So we would educate the caregivers or parents to avoid smoking while the child is home. Next is Down syndrome due to eustachian tube dysfunctions. Bottle feeding over breastfeeding. We have to remember that breastfeeding provides important protective antibodies to the child. Next, we have higher incidences of viral infections during the winter or spring months. For example, RSV in school-age children. This happens most likely during the winter and spring months at school because children are more likely to get these viral infections and transmit it back and forth to each other. Next, we have manifestations. So the manifestations for serous otitis media, also known as otitis media with effusion, would be cough, rhinitis, and upon assessment of the ear, there would be no inflammation. And if the child is able to describe the problem to you, they could maybe say that they heard a popping sound in their ear and they may complain of dizziness. The manifestations in acute otitis media are crying, fever, purulent drainage from the ear, rubbing or pulling at the ear, and if these manifestations continue and otitis media continues, there is a possibility for a speech delay or difficulty hearing. So here on this side, I have a few pictures. This one would be of the purulent drainage from the ear, and this would be the one of the baby crying and pulling at the ear. So how is otitis diagnosed? Well, first of all, we're going to assess our patient, and assessment in otitis is done through the auditory canal, and we view the tympanic membrane using an otoscope. In the first image we have is a pearly gray transparent tympanic membrane, and this is healthy. That's what we want to see. In the second picture, we have serous otitis media with a collection of fluid, and we do see some bubbles in there, but there is no infection present. In the third image, we have acute otitis media. We can see that the tympanic membrane is red, and it looks like we might have some edema going on around the tympanic, and that is considered bulging. Next, an audiometry test can be performed. So an audiometry test is when a probe records continuous tones delivered to the tympanic membrane, and we can see that being done in the two images here. Then we have a myringotomy. So I have a picture of a myringotomy here. There is an incision that is made in the tympanic membrane. This incision actually helps relieve some pressure, and sometimes we have drainage that comes out of it, and that drainage is cultured. Next, we have a CBC, culture and sensitivity. So the culture and sensitivity is done from the drainage that comes out when the tympanic membrane is perforated. The culture and sensitivity can better determine the kind of bacteria and the best medication to treat the infection. The CBC will show us elevated WBCs, and that is also an indication of infection. The WBC ranges for children under 2 years old, and the normal count would be 6,200 to 17,000. And children over the age of 2 or adults, the normal range is 5 to 10,000. Now we move on to intervention. And in intervention, we're going to talk about the myringotomy and the placement of the tympanostomy tube. As you can see here, the myringotomy relieves the pressure in the middle ear, and it prevents the eardrum from rupturing. The tympanostomy tubes, which are these little blue ones here, those provide continuous drainage and ventilation to the middle ear, and it assists with the healing process. We do have to educate the parents that this tympanostomy tube and the myringotomy is a surgical procedure, and for that we need to educate them that they have to avoid water from entering the ears of the child, so they have to use earplugs. We also have to remind them that the tubes will fall out on their own in about 8 to 18 months. And we have to let them know that they should be providing analgesics to their children to help with the pain. We also have to let them know that if the child's symptoms or their pain gets worse, that they should be contacting their healthcare provider. In nursing and therapeutic care, we are going to make sure the children stay up to date with their immunizations. We will also provide comfort measures and educate the parents about analgesics and antipyretics. Here I have some examples of those. We have infant Tylenol and children's Motrin. We will also provide information or a prescription for homeopathic ear drops. Homeopathic ear drops are natural herbal remedies such as chamomile, and those help relieve some of the symptoms. And I have an example of that one here too. We also have to educate the parents about feeding the child in an upright position, kind of like what the mom is doing here. That's very important. And next, similar to upright position with feeding, would be elevating the head when the child is laying down or going to bed. Elevating the head slightly will help relieve some of the pressure and pain from that ear. Antibiotics is a pharmacological therapy, and it's probably one of the more important parts that we're going to talk about here, because many parents, when a child has an infection or they think it's an infection, they always go to the doctor and they want an antibiotic. And with acute otitis media, they think, well, since there is an infection, they should be getting an antibiotic. Antibiotics do increase the risk of developing resistant strains of bacteria, and most ear infections do go away within 48 to 72 hours. But if an antibiotic is prescribed, the first line would be amoxicillin. So amoxicillin is provided in 80 to 90 milligrams per kilogram per day. So we have to educate the parents that when the child starts this treatment, they must complete it. and they must take it as prescribed. The goal is to provide comfort for the child and help them remain free of pain, fever, and infection. So these are the things that we're going to do as nurses for our patient and for the family members. In 2019, the Department of Pediatrics at State University of New York published some research called Association Between Otitis Media Infection and Failed Hearing Screenings in Children. What these researchers determined is that many of the children with the recurrent otitis media infections failed their hearing loss test because they were more likely to have an effusion at the time of the test. They also found that many of these patients that had recurrent otitis media led to chronic otitis media with effusion. Reoccurrent and chronic otitis media is often treated with the tympanostomy tube placement. The issue with this is that this surgery can leave scarring in the tympanic membrane, and this scarring can actually lead to hearing loss also. During their research, they actually also found some interesting information. They found out that even though screening for hearing loss is encouraged for all children and adolescents, there were less adolescents being screened for hearing loss, even though some of these adolescents had a history of acute otitis media or a chronic otitis media with effusion. The researchers believe that maybe some of the healthcare providers assume that there are no issues with hearing loss because the adolescents have not complained of issues with hearing. The problem with this is that throughout the years, they have noticed that there is an increase in noise-induced hearing loss in adolescents. So they determined that if a child had a history of failing a hearing screening, that this child should continue to be evaluated even in adolescence, even if there is no complaint of hearing loss or otitis infections. As nurses, it is important for us to collaborate with other healthcare professionals, and in otitis, we can collaborate with audiologists. Audiologists are healthcare professionals specialized in auditory and vestibular disorders. They can help identify, diagnose, treat, monitor, and conduct hearing screenings. We also have speech pathologists. Speech pathologists, they assess age-specific speech development, and they can help maintain proper verbal communication, and they can also help develop a teaching plan for these children. I don't know if you remember, but I did mention that children with otitis are at risk for hearing loss and speech delays. Lastly, I'm going to go ahead and demonstrate how to properly administer eardrops to a child under 3 years old. So we are going to go ahead and take hold of the pinna, and we're going to pull it back and down. That way we straighten out the ear canal. We're going to make sure we have our eardrops, make sure they're not expired, that we know how many drops we're administering. Go ahead and do that. Going to let go of the pinna, and we're going to make sure our child stays sitting up for a few minutes. And that is all. Thank you very much for watching.